All right. So as Elaine mentioned, earlier in the year, we were kind of asked by Health Education England and NHS England to kind of carry out an assessment of the long-term workforce plan. And over the next couple of slides, I'll be detailing how we went about this process. But just to set some context, obviously, we all know how much of a problem workforce shortages have been within the NHS across different staffing groups. And we know that the sheer scale of vacancies has obviously worsened with demand increasing a lot for how we can balance and meet those requirements. The long-term workforce plan was eventually published in June 2023, so earlier this year, and I think we can all collectively agree it's a major milestone for how health workforce planning has been carried out within policy, and a very firm commitment from the government to kind of review this every 2 years. And finally kind of identify the issues in the lack of a workforce planning, what that might mean. But there are kind of really ambitious commitments to increasing the number of doctors and nurses and other staff in NHS England over the next 15 years. And at the time that we were approached by NHS England, this was obviously some months before the plan was actually published, which gave us a really good opportunity to achieve some impact in terms of feeding back to their process and how things might be improved. We can take a look at this chart, essentially showing how the size of the NHS workforce actually is, and that's that bold line up to about 2021, and the kind of lower and upper estimates suggesting here the scale of potential workforce shortages, or the kind of workforce numbers that we might be able to achieve if the plan is implemented and achieved in full. But of course, we recognise these are really ambitious, and you can see kind of where the trend line heads towards 2036. It's a lot lower than either of those estimates. So there's definitely a lot of work to be done in order to achieve those commitments that the NHS England Workforce Plan commits. So in terms of how the plan and the Health Foundation's role in carrying out this piece of work was conducted, we were approached by NHS England colleagues to really kind of check the structure and their approach and how their model was set up and what kind of inputs were feeding into the model. We'd also want to kind of review the steps that they had taken to generate any of these outputs, to sense check some assumptions that they had made, and ultimately a sense check of the scale of impact and what they were proposing. The main reason for this and why we were approached was obviously to provide an independent perspective outside of NHS England and government. And this also followed off the back of our workforce projections report, which was published in 2022, so the summer before. And this was deemed to, and I quote, to have had the kind of most relevant experience and expertise in this space. And this is a really big indication of the kind of impact that we can drive with the work that we've been doing in supporting government thinking about workforce numbers and shortages. The task itself was to assess the process against an accepted framework, and the framework that we've chosen was obviously a government organised quality check against certain domains. The way that the process, you can imagine how can you really conduct an analysis of a workforce plan? Well, there was a lot of documentation provided to us by NHS England that really varied, either Excel spreadsheets or assumptions lists or correspondence notes or kind of diagrams of the workforce plan model and how different sectors fed into different parts, and to varying levels of granularity as well. So some of it was very specific, and others were kind of more broad-based assumptions or conversations that had been had with stakeholders. And accordingly, we also set up a lot of workshops with NHS England colleagues and our internal Health Foundation experts on different areas of workforce supply, but also on healthcare demand and funding, and trying to get an idea of where we could really sense check and challenge where necessary, where certain assumptions had been made. The process obviously had to rely on a lot of adaptive project management. It was a novel kind of task for us to carry out as an organisation, and we knew that it was very sensitive, not just politically, but also time-wise and the implications for it, and ultimately work towards drafting an output and agreeing on what that output might look like, and eventually publishing it once the plan had been published itself. And when we were provided this task, we actually only had 2 weeks. So you can imagine just how rapid this review was, and kind of the scale of the work to be done in the time that we had available. So I've shared on this slide a very high-level view of the assessment framework that we carried out against the model and the kind of level of assumptions and all of those documents that I mentioned earlier. And these are kind of the 4 domains that come from published kind of guidelines, principles on how modelling and methodology should be carried out from the government in line with the AQUA principles. So you can see that the first one was really, the first 2 looking at quality, looking at the suitability of data sources and the methodology. And ultimately for methodology, we really were keen to identify kind of transparency and limitations, as these would obviously have huge implications on the validity of the model going forward. The third and fourth domains were more to do with value. So we were interested in looking at how these findings could be interpreted and really look towards kind of an appropriate comparisons. And we recognize that workforce planning internationally is almost a very recent phenomenon. We are hearing about workforce planning being carried out in certain OECD countries at present, or kind of finishing off those rounds. So we can see that this is definitely new areas to cover. And the final domain on value, on innovation and improvement, really wanted to press that commitment to updating the model and being able to kind of sense check it in a reasonable time period to make sure that improvements were being made to its methodology and its development, and whether it would continue to be robust in the years going forward. So as you can imagine, we've got 2 weeks. Anissa Charlesworth, head of Real Centres, of course, a key instrumental figure in terms of determining and receiving this work and engaging with Health Education England, Navina Evans, and working on kind of getting and managing our expectations, not just for them of us, of the work that we would do, but also the other way around, and really kind of building a strong relationship with Health Education England. And whilst it may have felt a little bit like this during the process of planning, one of the ways that we managed to carry out this work was having a really clear planning approach, which looked at kind of development of how we would conduct the analysis ourselves and reorganize capacity within the team. One of the main things that we were obviously very concerned about is the risk approach to this piece of work. We knew that there were huge implications, not just for the kind of strength of the assumptions that were made, but also how those implications could play out in the field. And given the scope that we had and the time period that we had, being able to manage those expectations in terms of what the verification assessment was, just of its modelling and its assumptions, and not of the results that it had found, or kind of how it had, whether those were kind of feasible for the purpose of planning for the workforce. And that work obviously came later, as Elaine will cover later on in the presentation. In terms of the actual doing part of the verification, as I mentioned previously, a lot of documentation, logging of various types, being able to schedule these workshops across different colleagues inside NHS England and within the Health Foundation, and ultimately agreeing on an assessment framework that made sense and was objective enough to provide that independent perspective that was required of us, and ultimately agreeing the output, which eventually was a cover letter and a full kind of print through of the assessment that we carried out when we carried it out. And we also obviously had to check what we were doing. As I mentioned before, this was a novel task for the Health Foundation, for the Real Centre, and given the fact that the workforce plan itself was very new. So a lot of kind of drafting and updating, and one of the things that we experienced during this process ultimately was, in response to questions and in response to workshops and in response to challenges, we would have new pieces of documentation from NHS England. So really being able to get a scope of what was clearly a very complex and interconnected model from NHS England to establish these kind of numbers and thinking, and really being consistent in our messaging across the outputs, and being very thorough in what we had received and combing through for whether they met those domains. So ultimately, this was an iterative process, obviously, in the time that we had. And the key findings that we had off the back of this review was ultimately that the model was underlined by very rich and internally held data. As I'm sure many of us on the call can appreciate, the data set that NHS England might have access to will have been, as clear a picture as you can get compared to the kind of research that we do without that access, whether that's electronic staff records or various other pieces of information. But there was also kind of qualitative data that had come about through internal communications with heads of departments or heads of specific treatment areas, and really trying to understand what those numbers might look like. We mentioned a wide range of documentation, and ultimately that also led to variation in the quality of these documents. Some of these would relate to interlinkages with other pieces of information that we did not have access to, obviously those being deemed commercially sensitive. But others were obviously part of a small cog and part of a much bigger machine, really, and trying to understand how those different components can align and interlink. Required a lot of thinking and understanding whether the documentation provided actually met that criteria. One of our main findings and one of our main points of impact actually with the work was to kind of really highlight to NHS England that the uncertainty within the model was well documented and considered, but there hadn't been consideration of epistemic uncertainty. So whether or not the model that they had selected and the structure that they had chosen were actually fit for purpose, or to the extent of the finding, to qualify the findings that they had achieved. And being able to encourage this thinking of NHS England was really crucial. Obviously, we carried out this assessment in February, and the assessment wasn't published. Sorry, the plan was not published until June or July. So we had a brief window of time actually for NHS England to take back our findings and implement them and improve the plan that way, which was a great opportunity for us. We obviously mentioned as well that the documentation on those modelling decisions for those that were sensitive meant that we might not have had access to the full picture. And this is obviously something that, since learning, obviously, with the National Audit Office, who are conducting their own assessment of the model, will have access to these documents. So for the purposes of our assessment, perhaps it was not necessary to see where these individuals' decisions had come through, but for kind of the wider kind of assessment of this model by the NAO, we can expect that all of these documents will be combed through thoroughly and inform a clearer picture as to how certain decisions or assumptions were made. We recognise also that there was a presentation of downside risk to avoid optimism bias, and this was perhaps missing from the long-term workforce plan. It would also allow us to kind of better reflect uncertainty of assumptions and interventions. And one thing that we are also aware of ultimately is that at the time of drafting, NHS England, the workforce plan, hugely a commitment from government and something that obviously had costs attached to it, was very politically sensitive. We recognise that there may have been kind of pressures to drive up certain expectations or ambitions, and these are things that ultimately will affect how feasible and reasonable the commitments will be going ahead. And ultimately, the main thing that we can celebrate is the commitment to an ongoing process of improvement, transparency, and sustainability. And having attended very recently, along with some others on the call, most likely an NHS England Long-Term Workforce Plan Summit, there is a very keen appetite amongst NHS England leaders to really commit to this plan and to identify potential data improvements or lived experiences or assumptions or changes that can improve the plan going forward. And this is really, really very rewarding to see and something that I'm sure we're all very grateful for going ahead. Once the plan was obviously published, we did have some further observations on how the plan might have been improved. And ultimately, we, as I mentioned before, our suggestions on sensitivity analysis were then included in the updated projections, which allowed us to not just have impact, but also a meaningful impact in that providing the sensitivity analysis avoids that optimism bias and really tries to provide a reasonable or realistic approach to the kind of numbers and growth that we might expect to see within the plan. We also noted actually that the assumptions on projected productivity improvements over the next few years, 15 years actually, were hugely ambitious. They were not sufficiently evidenced at present, and they would just require a huge increase in productivity that has not been carried out historically. And we obviously know that productivity currently within the healthcare system is a lot lower than previous years. Some of this might be related to obviously the COVID-19 backlog, but we recognise that there are a whole other range of factors feeding into productivity relating to capital or weakening infrastructure. And these are things that the plan did not go into sufficient detail on, raising concerns over whether the productivity estimates were perhaps a little bit ambitious. We recognise that the plan obviously takes a nationwide approach, and that's true also of our workforce projections report from the year previously. But it's also important to recognise that there are regional variations in need and labour demand and supply, and these have implications for inequalities in terms of healthcare access and outcomes. And so it would be advised, or it would definitely be something to work towards, having those regional iterations of the model, or that granularity, to really drive in a commitment to ensuring the health and care system can meet the needs across the country and not just apportioned for England as a whole. And finally, one of our most important kind of drawbacks from the model, and is reflected in a lot of our other workforce work, has really been the lack of a consideration of wider labour dynamics. Not just pay, which we understand to be hugely topical at the moment. We're obviously seeing announcements just in the last few days of the longest strike action from doctors, and off the back of nurse industrial action as well, but also kind of the terms and conditions within NHS environments and how these might compare to other sectors, and therefore having implications on retention of these experienced staff, and also turnover and churn within organisations. So we observed that obviously without wider consideration of the impacts of pay and these conditions, it's harder to be able to say that this is how many workers we might need by the end of a certain time period, without really taking into those external factors that can motivate their decision. And so I'm going to pass over now to Elaine to carry out the training commitments part of the presentation.
Thank you. What I might do actually, Nuha, to avoid you having to be me having to do a Chris Whitty, I might share my version of the slides and then you can relax. Can people see that now?
I think we can see your teams.
You can see my teams. Okay,
yeah, the teams good. Meeting.
Okay, that's not good. Let me see if I can do that again. Be less incompetent. Okay.
That's it.
Perfect. Okay. Thank you very much, Nuha. So let me just slideshow. Is that even better? Is that all okay?
Yes, it is. This is good.
Perfect. Okay. Yeah. So in the short term, the training is really a long-term part of the long-term aspirations of the long-term plan. So in the short term, improvements in staff numbers are going to mainly come through retention and also international recruitment, which, as Joe was speaking about at the beginning of the session, is really a whole other topic in itself. However, in the long term, there's a real focus in the plan about increasing the number of domestically trained staff. So for clinical roles, the plan commits to a major increase in the numbers of people going through domestic training, both at undergraduate and postgraduate level, and also very crucially for in terms of apprenticeships, which both kind of widens the pool of applicants in terms of job roles. But actually, we were hearing from NHS England earlier in the week in a meeting that it also can affect the geographical distribution, because if you're in a university setting, you're restricted to particular areas of the country, and that's less so with apprenticeships. These commitments were backed with around £2.4 billion in funding over the next 5 years. That is explicitly for the training, and as I'll come on to later, there are bigger numbers that are floating around for what might be needed to actually implement the plan long term. And what I'm going to talk about in the rest of this talk is firstly the impact that might have on kind of training numbers and the composition of people in training, but also a little bit more on the health system and the wider economy. So this you've probably seen. This is the what the plan to increase numbers. The overall, you can see at the bottom of the screen, is an increase of around 150 to 165%. So a 50 to so a really big increase in staff numbers. What we did was in our piece that prompted the invitation to give the seminar was to look at what do these are very big numbers coming from mostly kind of young people between sort of 18 and 34, although not entirely. There's a bit more in some professions like nursing from older students. What does that mean for what universities or training providers might look like in over the next 5 to 10 years? So what we did was we looked at the total number of students enrolled and looked at how that had changed over time. There was a pre-pandemic average growth rate of around 1.1% for first year enrolments. I was interested to understand whether that reflected the change in the population of kind of younger people. That did not. It just seems to be independent of that, which is interesting. And we've made the assumption in our analysis that in the absence of policy shifts, this will continue to hold. So what happens if it's implemented? Well, the chart on the right shows the number of student enrolments, nursing student enrolments, but by degree course, or the number of enrolments in 22-23 first year enrolments, and then by 21-32 what was planned, what came out of the plan. You see a very big increase for nurses and health visitors. What we find is that combining that with what we're expecting to see to the number of university places, the number of students training to be NHS clinical professionals would take up about 1 in 6 of all first year students in 2031-32. That's up from 1 in 9 in 22-23. So this is really having a kind of marked effect on what goes in with in our higher education institutions. Now, if we break that down, we see that around 2/3 of it is coming from nurses, an increase in nursing and nurses and health visitors, and that's alongside a big increase actually in nursing associate roles. There's also a big increase percentage-wise, doubling in the number of medical school places. And there's, as I mentioned before, there's a very big increase, which is not shown in this chart, in the role of degree level apprenticeships, rising from 8% of the registered. So even if we're looking at nurses, that's 8% of the registered nurse intake in 22-23 to 28% in 32-33, 31-32. For nursing associates, the increase is from 30% to 50%. So we're really changing the volume. We're changing the staff mix, because you can see that some professions are, some courses are increasing more than others, and then we're also changing the route. So there's lots of moving parts at exactly the same time, which is interesting and will be challenging to manage. So the next question we thought about, okay, is we know we can model what we think might happen to numbers, we can model what we think might happen to universities, but just on the kind of training side, what is this feasible? Are these big increases in the number of students, in the composition of students, feasible? We're still at the early days of our conclusions on this, partly because we're sort of awaiting more detail. So what it's going to require is making sure that we efficiently allocate the promised 2.4 billion. And there's going to have to be some close collaboration between universities and other stakeholders on placements to ensure that there's effective supervision and to integrate placements into service design. One thing I would say is that, which is encouraging, is that the Council of Deans welcomed the plan and has been involved in every stage of the plan development, engaging and having their voices heard, which is promising. That doesn't guarantee anything, but it's certainly better than the converse being true. On top of this, on top of the ramping up, which is one layer of complication. We also have this commitment to change, to increase the number of degree level apprenticeships, and that is so far untested and needs further planning. So there's the university side, but because there's so many moving parts, we can't really lose track of the other things that are going on, and all of it is going to be required if we're going to see this really quite considerable increase in workforce numbers. The second thing it's not just, it's a very important part of system capacity is the educator workforce. So they're the people that are going to be required to deliver the training, and with the clinical workforce, this is people not just obviously in the classroom, but also on the ground, providing supervision and treating patients. Now, I went to I think it was a General Medical Council meeting earlier in the year, where they were talking about different ways in which this might be achieved. There's going to need to be some increased use of simulation-based learning techniques that we now have those. The capability to do that more. There is also, we need to effectively implement the recent educator workforce strategy, and actually it's encouraging that has been put alongside the long-term workforce plan. The important thing to point out is actually at the moment at that meeting there was a big focus on undergraduates, which for good reason, because that's what's going to grow first, but actually particularly for medics and to a degree the supervision of newly qualified other clinical professionals. There's going to be issues along the path. So for medics, they also need foundation training placements. They're also going to need core specialist training placements. You're going to need GP people training specialist GPs when they're doing specialist training. So given that this is a long-term workforce plan, it will be important both to think about the educator workforce for undergraduates, but also all the way through. There is an ongoing debate about whether it would be possible to reduce contact hours for nursing training. Our colleague at the Health Foundation, Jim Buchan, has been working a long time on this issue, and his view is that the number of hours that we require before completing training is much higher in the UK than it is in other countries which we may compare ourselves to, like Australia. Now, I imagine that there is, I know there's still some resistance to that, but that is something to look at. There were also discussions at the meeting of the General Medical Council about 4 and 5 year degrees, but I think that is also still ongoing. This was something that I thought was interesting. With the increased number of undergraduates and then subsequently people moving through specialist training, through foundation and specialist training, one of the concerns will be on the impact on trainers. And there's a national training survey that gets done every year, and we can see that since the pandemic, since 2021, there's been increases in risks of burnout for both trainers and trainees. And clearly, more students without more trainers is one potential reason why that situation might get worse. And so this is something we've got to keep an eye on. The last thing I wanted to talk about was we've talked about system capacity, but we also need to think about the people who might want to do those courses. So the nurses, doctors, physios of the future. So in some sense, the long-term workforce plan is reasonably well timed, at least for the first period, because there's an increase in the projected population aged 18 to 24, who form the majority of the undergraduates enrollments in medicine and other subjects, and even in nursing, 18-year-olds are the biggest single group of people going into nursing. Between 2023 and 2024, 23-24 and 32-33, the number of 18-year-olds 18 to 24-year-olds is projected to grow from 4.4 million to nearly 5 million. due to the relatively large birth cohorts between mid-2000s and mid-2010. You look at this chart of the ONS mid-year estimates from 2021. We're sort of at the moment kind of in the dip on the right hand side of the number of 18-year-olds. So this will be that now in 2023. This would be the number of 16-year-olds finishing school. The period. So I've marked the people that are going to be 18 in 2032 and 24 in 32. Unfortunately, it's coming in a period where we have more than we've had. The challenge being, if you look on the left-hand side, it's now followed by a period where there's been a declining birth rate, and so we don't think the demands of increasing the workforce are going to reduce after that. This is not a one-off growth. This is a kind of permanent increase. So at that point, you're going to want an increasing number of people from a smaller pool. So the growth in the number of kind of younger adults implies a smaller impact of increasing training places on the number of people available to go into other courses, because obviously health is one thing that's important, but there's lots of other things that are important to the economy, including in the public sector and teachers and so on, but also in the private sector. And then but this is a short-term gain, and so we're going to need to think what to do at the long term. The other benefit being that it should have less impact. If you're growing the number of young people, it should have less impact on who the marginal applicant is. So if you were to keep the number of people that can possibly apply constant, and you increase the number of places, then the average grades or whatever competency level that you're going to need to achieve is going to go down. But this counteracts that somewhat. The other, as well as the number of people that there are to apply, we also need to think about the preferences of those people. It's not the only health and care is not the only job that one can go, or sector that one can go into. After an increase in applications and acceptances for nursing in the past couple of years, there was a fall this year. So what I was thinking about over the past couple of days is in 2022, looking at the most recent UCAS data, there were 56 applicants for nursing degrees, of which half of those got accepted. Now this is very close to the 54,000 in the 2031 plan, as in we don't have that much wiggle room. Now, while there are probably some nursing applicants that didn't get a place that could have been very good nurses, there might be a concern that there's probably some, even on in terms of that we might, not every applicant might be suitable, and it could also be that we end up with fewer applicants than places for the first time. And that's quite worrying. So there was a real question, particularly for certain degrees where there's really big increase. There's going to be a really big increase in training places. We're really going to have to make sure that those careers are attractive to potential applicants who do have other options. Okay, so I'm just going to finish by talking about some wider implications that weren't focused on in the long-term workforce plan. The first is funding. So the funding announced in the long-term workforce plan just covered training and not the subsequent costs of employing a larger workforce. And actually that is much bigger than the 2.4 billion required to that's been allocated to facilitate the growth in training places. So my colleagues at IFS have estimated that, making certain assumptions, the long-term workforce plan implies annual NHS budget increases of around 3.6% a year, or a total increase of about 70% by 2036-37. Now that's in line with long-term growth of NHS spending, although not higher than spending over the past decade or so. That doesn't include any of the modernisation that one might want to include based on the ambitions of the NHS. that we will also need an increase in capital investment if we are actually going to see this workforce achieve what the aim is for it to achieve, and also for productivity to be realised. And as Nuha mentioned before, there's very ambitious productivity assumptions. Now, what you would expect is if you just put more and more workforce in and you don't provide them with the tools to do their job, then the amount that they're able to produce, the amount of care that they're going to deliver is not going to go up as much. So achieving the long-term work for NHS England themselves said that achieving the ambitious productivity growth will require a sustained increase in capital investment in the ageing NHS estate and an investment in digital infrastructure throughout the NHS. So this is really, the NHS workforce plan is one part of the puzzle. And actually, if we don't address other parts of what is needed to deliver healthcare, then those workers could be left kind of disappointed and without the tools that they need. Okay, the other thing that I wanted to talk about, the last thing I'm going to talk about is the wider implications of the workforce, because actually, while it means a change in the composition of training places that I discussed first, it also means a change in the way in the composition of the workforce. So this is a chart that Ben and Max produced looking at public sector workforce. So by 2036, we might expect around half of public sector workers could work for the NHS. Now, that is not saying that's a bad thing. And actually, as we get richer, we might want to spend more on health. We have more older people and so on. But that's just really quite a large, very large share of the public sector workforce. And the other aspect is it also feeds into the whole economy. So but again, by 2036, we might expect 1 in 11 of all workers in England to work for the NHS. That again is a choice. That is not this is not necessarily it's not a bad or a good thing. It's just and it's probably required to deliver care for a larger, older, a population with more comorbidities. But it also it just has implications for the structure of the economy. There are the rest of the economy at the moment has to generate tax revenue to pay for the NHS and NHS workers' salaries. And so we have to think about whether we have enough of those workers in the private sector and the rest of the public sector who are able to do that. Conclusions. So yes, the workforce plan has been rightly welcomed, but it's really a starting point that has to be supported with other work if it's to be successful. And I think the government do realise that, and the noises are the right ones. It's just making sure that happens. So everyone's asking for more information about how we to deliver that plan. We also need a funded plan for what I could call workforce enablers, especially capital and technology. We need to rebuild the NHS estates, what the workforce with the tools that they need, and that is what is crucial to achieving productivity gains. It's not a case of working harder. It's a kind of working smarter argument. Expanding domestic training is going to require both having sufficient capacity, so it's both the educators and the system capacity, and also a willing pool of suitable applicants, which, as we noted, might be feasible over the next 5 years. But if we keep having low birth rates, we might struggle with in the future. And in the near term, really, we need to focus on improving staff retention and investing in capital estates, and to a degree, recruiting from abroad. And that will arguably have the biggest impact on the NHS, and also on how attractive it is as a proposition for those starting higher education or choosing what they want to do. And that is the end of the slides.
Thank you so much, Elaine and Nuha. That was fascinating. It was absolutely brilliant to be able to hear about the process, about how you actually collected all the data and analysed it, and then to sort of see the way that you explored it. So what I'm going to do now is I'm going to stop recording,